decided already. I opened my car door too, so we could catch a cross breeze. The sky darkened even more, and I thought of all those little stars.
Morning.
Morning.
How's it going?
I know a lot of people had internet issues last night. And they may still be having them. So, but let's give well just a few more minutes to see if they, or another minute to see if they show up. Not a few more.
Did you all get the rain and thunderstorms?
I had a little bit. I was actually, I drove back in it from Stevenson University. And it was bad, but I think it was much worse before I showed up. I know Becky had them.
Oh,
Yeah, I had them too.
yeah,
Wow.
we lost power and stuff. So my internet was not, it's still not great today either.
Wow.
Doesn't help we live in the mountain and there's trees and everything else that go down and stuff.
Oh, wow. I was, when you were saying you were out of power, I didn't have a chance to respond last night, but when you were saying you were out of power, I thought, am I gonna go home to a house that's out of power? I did not want to do that.
Well, and we live on a driveway where there's only 10 of us and we each have like 5 acres. So we're always like the last one that they care about because we're not a neighborhood full of people without power. So yeah.
Oh, okay. You know that you're at the bottom of the list.
We are, yep. And even running a generator doesn't help my Wi-Fi. So yeah, I could not get on last night. I tried and tried, but yeah, no.
Do you have pump water?
Yeah, we have a well.
Oh, see, okay. I told when we had power go out here for 18 hours. When was it? During the storm, probably right around spring break. I told my mom, I said, I'm just grateful we don't have well water. Because when I lived in Frederick with my brother, they had well water. When the power went out, the water went out too.
Yeah, fortunately I have boys, so my husband's always like, just go outside.
See, well, that works, but what does it do for you? I mean,
I legit just like have one bathroom and I'm like, I'm just will not flush it till we're good to go.
Well, I mean, and you can't shower. The 18 hours was a long time for me to be without power, but I was really happy we had running water all the same.
Yeah, for sure.
So let's jump into today and see, if more people are able to get on. Hi, Miss Gessel. This is there that I started out but did not finish. Alexa, send me an email and just remind me if I don't fix it this afternoon. And you guys, if you'd be willing to turn on your cameras, I'd really appreciate it. So I don't feel like I'm talking to myself here. Thank you. Um, let's jump into today. And so we're looking at the pulmonary system, and I am debating skipping a lab and doing a lecture instead, not today. I'm trying to remember, and I was looking at it last night, and it's really funny because I can't remember what was on the syllabus for next week. But I'm gonna just open it, show you what I'm looking at. So HAC semester ends, or our semester ends, right around May 6th. And this is where we are right now. This is what chapter we're covering today. We can put the reproductive system into one week. We can possibly put the digestive system and metabolism into 1 week. But we definitely want to go over fluid and electrolyte balance and acid balance. You're going to see when we go through the fluid and electrolyte and acid-base balance that a lot of it is a review of what we're going to see in the respiratory and the urinary system. Because guess where we do fluid and electrolyte balance? It's in the respiratory and the urinary system. And the acid-base balance, it's in the urinary and respiratory systems. So I definitely need to cover those. And this is going to be a shorter chapter. Chapter 24 will be a shorter chapter. But it ties the respiratory and the urinary system together. And it'll make more sense when we go through it. But I'm just thinking through how we can cover what we need to cover. And so I may do that next week. We may skip a lab and combine it with another lab. Because I'm realizing that a lot of the Wiley exercises are for the digestive system and chemical and mechanical digestion, they are very much the similar and same questions. And so let me think about this for a couple days. But the other thing that I wanted to bring up is I sent you the urinalysis strips. If you don't have them, let me know. I still have some that I can still send out. But I don't want to do that lab today. I don't want to do that part of the lab today, and it's because I didn't give you the instructions as to how to prepare. If you really want to, you can test your own urine, and I'll tell you what the company is, and they are Q-Test. Q-Test, not that one. Q-Test. Analysis strips. This is the chart. And so if you want to, you can test your own. You can test somebody else's. All you do is soak the strip for a second and take it out and let it sit for a minute or second or excuse me, about 2 minutes. But I wanted to give you there's some recipes for experimental urine. I posted them, but I don't think giving you an hour and a half today is going to give you time to prepare. And I know that not everybody gets the emails or reads their emails. And so I didn't send out an email on it and expect everybody to see it.
Do you need us to get all of the ingredients? I did look at
You
the
don't have
list.
to get all the ingredients. I would do 1 or 2 if you wanted. But see,
Okay.
Claire, you did it, but I don't think a lot of students did do it and get ready for it. So what I want to do is honestly maybe even put it off a week. Go through it and start a different lab, but touch on this again next week. Does that make sense?
Yes.
Because I don't think that I realized I'd forgotten to do it after class last Friday to talk about it. I posted it, but I hadn't talked about it, and I don't think everybody saw it. And if you don't have raw meat hanging around, which a lot of us don't, one of those will not work for you. And if you don't have lemon juice around, one of those will not work for you. I'm trying to remember what other ingredients there were. Bear with me just for a second here.
I remember bleach being one of them.
Yep, bleach. One second here. And I honestly would prefer to go over the urinary system in lecture and then talk about it. Because I think that between the lab and lecture, you get the information you needed to really evaluate what you're looking at. So it's this right here, urine recipes. So one of them is water with 4 drops of bleach. One of them is water with some soda or pancake syrup, not sugar-free soda, or pancake syrup, and egg white. One of them is water, egg white, vinegar, and a few drops of blood. Raw meat is best. And one of them is water with lemon juice in it. And not all of us carry those ingredients all the time. And that's why if I'd remembered to go through it with you at the end last time, I would have done that. But I would prefer to wait until we do really go through it in lecture too. Would that be all right?
Sure.
Yes.
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 All right,
Yes.
let's jump into lecture and go through the pulmonary system. So the respiratory system, and it's chapter 22, not chapter 21. But major functions of the respiratory system: to provide an extensive gas surface area between the air and the circulating blood, to move air, oxygen, and carbon dioxide to and from the exchange surfaces of the lungs, to protect respiratory surfaces from the outside environment, to produce sounds, and to participate in the olfactory sense. One thing that we don't have here that's really important also is to be involved in acid-base balance in the body, which we'll talk about more. The major organs are the nose and nasal cavity and paranasal sinuses, the pharynx, the larynx. If you're not sure how to say those words, I think of sphinx when I say it, and add that with it, and then I say it right. Pharynx and larynx. The trachea, the bronchi and their branches, the lungs, and the alveoli. It's divided into two major tracts anatomically: the upper respiratory tract and the lower respiratory tract. The upper respiratory tract goes from the nasal cavity down to the larynx, including the nasal cavity, the hard palate, the pharynx, the soft palate. The lower respiratory tract includes the trachea, the bronchi and bronchioles, and the lungs, and the pleura. And I think you could possibly include the diaphragm in this, and we'll talk about why that's so important. But we really only consider that a muscle. We don't think of it so much as part of the respiratory system, even though it's key to it at the same time. So upper respiratory tract, nasal cavity to larynx. Lower respiratory tract includes the trachea and the lungs and the pleura. So the upper respiratory tract extends from the nose through the what?
C, larynx.
Yep, the larynx. So anatomically, the upper and the lower. The upper including the nasal cavity and the larynx, like Becky said. The lower including the trachea and bronchi and bronchioles and lungs. Functionally, it's divided into the conducting zone and the respiratory zone. This is going to be important later. But right now, the conducting zone serves as conduits to the gas exchange. It includes the nose, the nasal cavities, the paranasal sinuses, the pharynx, the larynx, trachea, and associated structures. What I would think, another way to think of this is the tunnels of where the air is moving. Just like when we were talking about blood, and I was telling you, think of it like a fluid. Think of this as similar. We're just dealing with a gas, and gases oftentimes have the same physical properties as the blood does and fluid does. So the conducting zone are the tunnels leading to the respiratory zone. the site of gas exchange. The respiratory zone includes the respiratory bronchioles, the alveolar ducts, and the alveoli. So starting with the conducting zone, looking specifically at the conducting zone. The conducting zone includes the root, looking at, the nose includes the root, the bridge, the dorsum nasal, the nasofacial angle, the apex, the tip of the nose, the nares, the nostrils, nasal septum. For people having a deviated septum, this is what they're referring to, is when the septum isn't straight or it's possibly been broken and caused it to deviate and not be down the center and maybe blocked one of their nasal and moved a little bit into one of the halves of the nasal cavities. And then looking at the cartilage and the nasal bones, the nasal bone, the lateral cartilage, the septal nasal cartilage, the minor and major alar cartilages and dense connective tissue. I used to say for a long time that normally when people get their nose broken, they're not so much getting their nose broken as they're getting the cartilage separated. And I'm now questioning whether I was saying it right then. Because one thing is the nasal septum is very much bone. And many times, most often, I don't know, more than likely, people who get their nose broken get that nasal septum broken. And that's what causes septal deviations. So I'm not going to say that anymore. I think it's a mixture of the bone and the cartilage. But mind you, the bone is a lot deeper. Looking at the upper respiratory system from a sagittal section. Here's your frontal sinus. Remember, frontal sinus meaning it's in the frontal bone. The sphenoidal sinus. Looking at the nasal cavity itself. Superior nasal, we have 3 different concha, which are concha meaning circular shells, shell-like shaped structures. The superior nasal concha, the middle nasal concha, and the inferior nasal concha. And underneath each of these concha, remember concha meaning like a shell-like curved in bone. Underneath each one of them is a meatus, a canal. So the middle, the superior meatus, the middle meatus, the inferior meatus. We have a pair of external nares, or the nares, and an internal nares, meaning nares meaning an opening. upper lip and the soft palate. Excuse me, hard palate and soft palate. The hard palate is solid bone from the maxilla and the palatine bone. I think I've told you that I was born with a cleft lip and palate. And what that means is that my lip failed to close and my palate was born without this bone intact. It wasn't a solid plate. And when I had braces from about the time I was in second grade, braces on my teeth, from the time I was in second grade until I was almost in 8th grade. Was I in 8th grade? Yeah, I think I was beyond 8th grade. I think I was actually a freshman in high school. And my orthodontist realized that there was no way he was going to be able to get my braces off and have my teeth not shift around because I didn't have bone to stabilize the top of my mouth. And so I ended up going to an orthopedic surgeon who took some bone from my hip, my os coxa, and inserted it into the top of my mouth. And I just remember waking up from that surgery, and mind you, I was 14, somewhere right around 14. And I remember waking up from that surgery and thinking that the bottom of my mouth, it's not the bottom of my mouth, the top of my mouth was a lot more shallow than it had been before the surgery. And it was very odd to me. Like I wasn't used to that. And I used to, before that surgery, I remember feeling like I had a hole that would drain from up here into my mouth. And when they did that surgery, that hole went away. And I was talking with one of my students at one of the schools that I teach at last year. And she was saying that she was born with a cleft palate. And not a cleft lip, but just a cleft palate. There's a range of it. And that she still had drainage. She could feel a hole or a cleft from her nasal cavity into her mouth. And my thought when she told me that was, did they really fix the cleft? Because I couldn't understand how she'd have drainage still if they'd fixed that. And I don't know. Yeah, it was very interesting to me when she said that, because I thought, did they really fix it if you can still have drainage? Because I know I don't have any drainage. Let's see what else. Okay, so that's the nasal cavity. So the vestibule or nasal cavity is superior to the nostrils. It functions as an airway for respiration. It moistens and warms the entering air and filters and cleans the inspired air and serves as a resonating chamber for speech and houses olfactory receptors. One thing that I'll mention this one more thing about the cleft lip and palate. If you listen to a lot of individuals who have a cleft lip and palate where they don't have, and it hasn't been repaired to the extent that mine has. I've had many surgeries on it. You'll hear that they have kind of a nasally voice. My dad was born with a cleft lip and palate, so for me it's a genetic. It's always a genetic thing, but for me in particular, it doesn't tend to run. We're learning more and more that it doesn't tend to run generation after generation. And his likelihood of having a child with a cleft lip and palate was 1 in 100. And it's in my family since I've been born. We're yet to see it again. But the reason I mention it is because when it says it's a resonance chamber for the speech, if you listen to individuals who have a cleft lip and palate and it hasn't been repaired or extremely well repaired, or they have not had some major speech therapy, the result is that they can have kind of a nasally voice. And I don't have a nasally voice. And part of that is because I did have a lot of speech therapy. I have a little bit of an accent that's kind of strange sometimes, but what it is it's a very well compensated for, well compensated for and well camouflaged speech impediment. And the other reason that I bring this up is because when they did my repair on my cleft lip and palate, there was an issue where this little area right here gets tied back. Because if you don't when you repair the cleft lip and palate, if you don't tie this back, it pulls up. And it moves up further, giving someone more of a nasally voice. And so when I was 2 months old, they went in and tied this back. And when they did that, it was fine for probably, we'd have to ask my mom and she's not here this weekend. It was fine for probably a couple months to a year. And then I started gagging on everything and throwing up everything. And I quit growing for 1.5 years. Was it 1.5 years? I think it was 1.5 years. My mom says I weighed the same amount as an almost 1-year-old, that I weighed the same amount as an almost a 2-year-old. And she finally got somebody to go in, and for a long time they just told her that whatever she thought was the problem was not possible, and that it wasn't what she thought it was. And when she finally got someone to go in and actually release the flap that they had pulled back, they call it a pharyngeal flap. So they went in and they tied it back. And when she convinced them to finally release it, I quit gagging on everything and throwing up everything. And she would tell me, and she can even tell me now, she said, you were so little. And she said, and I'd walk in, and she said, and it'd be the middle of the night, and she said, and I'd hear this little, and she knew that she had like a matter of seconds to go in and run to me before I threw up all over myself. And so I went in and they released that tie. And normally that tie also helps prevent the nasally voice. But for some reason I got lucky and I had a long enough palate already that I didn't deal with the nasally sound that came with the voice. And it may have been the speech therapy that ultimately compensated for it. Who knows?
That's really scary for your mom. And
She will tell you it was really, she said that she actually did not take any pictures of me for a while because she kept in the back of her head, she kept trying to tell herself to be prepared to lose this child. You know, be ready to lose me.
that's sad.
Because
That's
they
really
they weren't figuring out why I wasn't growing. And that I was, you know, I was essentially you know, doing that failure to thrive. And they couldn't figure out why I wasn't growing enough. And when she tried to explain to them what they thought the problem was, that this was too big, they kept telling her, well, that's a 1 in a million chance, and it's most likely not it. And when my nose and throat doctor one time, because your ear, nose, and throat are very tightly correlated, when my ear, nose, and throat doctor went in one time and started listening to me as I was sleeping, he looked at my mom and he said, yeah, there's something seriously wrong here. And he said, well, what do you think it is? And she said, well, you're going to think that I'm crazy, but this is what I think it is. And he looked at her and he said, well, let's go in and reverse it and see what happens.
And here you are.
Yep, here I am, like 40 years later, 45 years later. But
Amazing.
yeah,
For
Yes,
modern,
God is
modern.
good.
yeah, it's pretty amazing, and mothers are pretty amazing.
Yes. Because, I mean, you hear stories from like third world countries where children still aren't getting the medical help, and, you know,
Right.
doctors will like donate their time to go to third world countries and do these surgeries for kids that have this.
Right. Well, and
Which-
when I was, I'll tell you really quickly one more. When the last time I had a surgery for my nose, I was about 28. And that was the last time I had surgery, and I still have PTSD from that surgery, but we won't talk about it. I'll never have another nose surgery because they're really miserable deals. If you've ever had a nose surgery, they're really, really miserable.
I've had sinus, I had a cyst in my sinus cavity, and yes.
How bad was it?
Oh man.
I've had my tonsils out. I was just born with bad plumbing in my head.
Okay.
Nothing as complicated as you, so I'm grateful.
Well, how
but
bad was the cyst?
I guess it wasn't that bad. I just remember recovery was difficult for the first one, and then I had a blocked eustachian tube
Okay.
a few years back, and that wasn't so bad. I just think surgery is horrible. Period.
Eustachian tube is this auditory tube back here that we'll
Yeah.
talk about in 1 second. But no, I just had a friend who had a surgery to remove cysts, and he was asking me, well, his wife was asking me, but how was the surgery? How was the recovery? And I just said, it's hell. I said I would not want to do it ever, ever, ever again because I just remember bleeding and bleeding and bleeding and bleeding and bleeding.
And it makes your stomach, it goes down into your stomach and
Yeah.
makes you nauseated.
Yeah.
You
Yeah.
throw bad. It's bad. I know.
Yeah.
I'm with you. What I find even worse is the pain meds. Like I do not deal with narcotics very well.
Yeah.
Like,
Yeah.
oh, horrible. Like I'd rather just take the Tylenol or the Advil. But
Well, I found out with the last surgery I had, I found out I have an allergy to Percocet, which is great because it means that I'll never have an addiction issue for Percocet.
yeah, I don't understand how people can take narcotics on purpose. I get buggy. Like it gives me paranoia.
Yeah.
It's horrible. Like I will refuse them. They're terrible.
Well, he put me on 800 milligrams. I was actually just talking with Professor Stevenson about this yesterday because when we realized I had an allergy to it, he put me on ibuprofen, 800 milligrams. And if you're not familiar, ibuprofen is a really good one for anti-clotting.
Oh, gee.
And so it, the bleeding was I just remember there was so much bleeding. And he went to take out the stitches around my nose and I'm just bleeding all over the place. And he said, this is the doctor. He says, do you have a bleeding disorder? Are you known for having bleeding issues? And I said, well, no. And then he's like, oh yeah, we have you on 800 milligrams of ibuprofen. And so I don't know if it was just that or what it was, but I remember going in, actually having to drive myself an hour the following week because there was so much bleeding that I just couldn't make it stop. And so, yeah, I have PTSD because I just remember it being just so, the bleeding was probably the hardest part for me, was how much bleeding there was. But yeah, they put you on narcotics because it makes sure all the blood that moves from your, the narcotics, and then you come out with raccoon eyes because all the blood moves into your eye sockets. And so if you've seen people right after a nose surgery, they have black eyes. All right, now I'm going to quit going on about that. And we'll quit talking about it. But olfactory mucosa lines the superior nasal cavity and contains smell receptors. If you remember, there is only a few places where you have bipolar neurons. This is one of those places. Here's the one side of it. Here's the other side of it. Here's the dendrites. Here's the axon. So remember, you have this cribriform plate in the top of the nasal cavity, which is part of the ethmoid bone, and it's got a bunch of little holes through it. And those little holes move down into your the little holes are where the dendrites and neuronal cell bodies are going to move through from the olfactory bulb right here. The respiratory mucosa lines the remainder of the nasal cavity, and it's pseudostratified ciliated columnar epithelium. It's mucus and serous secretions that contain lysozyme and defensins, and peptides that defend against pathogens. Cilia that move contaminated mucus posteriorly to the throat. And inspired air is warmed by plexuses of capillaries and veins. So the air is going to be warmed and humidified here. The cilia, remember, this is a major part with the lysozymes. This is one of your first lines of defense in your immune system. The sensory nerve endings trigger sneezing. The superior, middle, and inferior nasal concha, those bony protrusions from the lateral walls that increase the mucosal area and enhance air turbulence. During inhalation, the concha and nasal mucosa are going to filter heat and moisten the air. During exhalation, these structures are going to reclaim that heat and moisture. The sinuses you have four major sinuses: the frontal sinuses, the sphenoidal sinuses, the ethmoidal sinuses, and the maxillary sinuses. Their major functions are to lighten the skull and help to warm and moisten the air and act as a resonance chamber in speech. The pharynx is this common pathway for food and air that's commonly called the throat. It's divided into three major regions: the nasopharynx, the oropharynx, and the laryngeal pharynx. The nasopharynx is located posteriorly to the nasal cavity. So and the way that I remember the nasopharynx, the oropharynx, and the laryngeal pharynx is that the nasal is right behind the nasal cavity. The oral pharynx, I'm going to actually let me come to this one. The oral pharynx, oral meaning mouth. So it's right behind the mouth. So nasal, right behind the nasal cavity. Oral pharynx, right behind the mouth. The laryngeal pharynx, right posterior to the larynx, which is right here. Probably some of the easiest anatomical terms to remember because of the order: nasopharynx, oral pharynx, laryngeal pharynx. So the nasopharynx, located posterior to the nasal cavity and superior to the soft palate. There's a soft palate, nasal cavity. In the lateral walls of the nasal pharynx, the paired auditory tubes, or like Claire said, the eustachian tubes. You'll hear them also called the eustachian tubes, are found in the nasal pharynx, and they connect the nasal pharynx with the middle ear, allowing you to equalize the pressure in the middle ear with that of the atmosphere. The pharyngeal tonsils, right here, right on the very superior top of the superior and posterior wall of the nasopharynx, the pharyngeal tonsils. You normally only pass air through the nasopharynx, nothing else. The oropharynx, right posterior to the mouth, is a common respiratory and digestive pathway through which air and swallowed food and drink are going to follow, are going to pass. The lymphatic organs in the pharynx, with their mucosa and the tonsils, are going to be the first, provide the first line of defense against ingested and inhaled foreign materials. Excuse me, the palatine tonsils are on the lateral wall. Palatine tonsils right here. And the lingual tonsil, meaning on the tongue, is right here. So palatine tonsil right here. Let's come in. Palatine tonsil right here. Lingual tonsil right here. Lingual meaning tongue, palatine meaning palate. So both sets of these tonsils are located in the oral pharynx. The laryngeal pharynx contains the larynx, the voice box, which is lined with non-keratinized stratified squamous epithelium. Non-keratinized stratified squamous epithelium. It's going to permit the passage of both food and air. The larynx, moving down, the larynx is going to produce sound in humans and prevent swallowed materials from entering the lower respiratory tract. It's going to conduct air into the lower respiratory tract, and it's supported by a framework of cartilages, 9 pieces. There's 3 individual pieces and 3 cartilage pairs that are held in place by ligaments and muscles. So looking here, your epiglottis, which is going to block the opening of the trachea when you swallow, preventing food and drink from going down your trachea. Your thyroid cartilage, which you can feel. Your crical thyroid cartilage, and in between, your crical cartilage, and in between The thyroid cartilage and the cricoid cartilage is the cricothyroid ligament. Cricotracheal ligaments and the tracheal C-rings. Posteriorly, the thyroid cartilage, the arytenoid cartilage, it looks like a little bit of a horn. That's where the name arytenoid comes from. Corniculate cartilage on the very tip. So corniculate cartilage, arytenoid cartilage, which the very tip of the arytenoid cartilage is the corniculate cartilage. And the cricoid cartilage from the back, if you look, the cricoid cartilage is much wider posteriorly. This is all right here. This is all cricoid cartilage. On the front, it's much thinner. The cricoid cartilage is the only full ring of cartilage that's considered part of the trachea, because it's complete on the back and on the front. One other major cartilage to talk about here, the arytenoid, not the arytenoid cartilage, where were we? The cuneiform cartilage right here. Don't see it here, but it's actually attached to the corniculate cartilage. So thyroid cartilage, cuneiform cartilage, corniculate cartilage, arytenoid cartilage, cricoid cartilage. I have a glottis up here. So the larynx and cartilages, remember there's 9 altogether. There's 3 pairs and 3 individual ones. The thyroid cartilage is the most prominent in males. It increases in size under the influence of testosterone and is often called Adam's apple. The cricoid cartilage is composed of hyaline cartilage, and it's a thin layer on the anterior side and thicker on the posterior side. The arytenoid cartilage attaches to the posterior end of the vocal cords and increases in pitch and voice. Increases pitch and voice. Corniculate cartilage is paired also, and it's posterior. It's on the posterior superior edge of the larynx, made of hyaline cartilage. And the vestibular folds, or the false vocal cords, we see those here, vestibular folds, attached to the corniculate cartilages. So this is going to be attached to the corniculate cartilage. It'll look like this. The cuneiform cartilage is found on the posterior superior edge of the larynx, and it's made of hyaline cartilage also. The epiglottis is the most superior part of the larynx and is composed of elastic cartilage. And it closes over the trachea during, or the trachea / opening of the larynx, protecting food from moving down the trachea during swallowing. The tracheal cartilage forms the front walls of the trachea. The only cartilage here that isn't made of hyaline cartilage is the epiglottis. So which of the following cartilages are the largest?
C, thyroid.
It's C, yes. So looking here, looking at the vocal cords, here's the vocal cord, here's the thyroid cartilage. The arytenoid cartilage with the corniculate cartilage. Adduction of the vocal cords, closing them. Abduction when they're opening. The vestibular folds, often they look similar to the vocal cords, but they're not. So we often call them the false vocal cords, vestibular folds, and the vocal cords. The glottis is the opening moving down into the trachea. So the arytenoid cartilages are attached to the vocal cords. And the corniculate cartilages are on the tips. So the vocal ligaments, as I can't talk all of a sudden, the vocal ligaments attach the arytenoid cartilages to the thyroid cartilage. They contain the elastic fibers and form a core of vocal folds. The opening between them is the glottis. And when the folds vibrate, the sound is produced as the air rushes up from the lungs. Please, yeah, any questions? Tracheostomy has to do with the cricothyroid ligament. So here's your cricothyroid ligament right here. Excuse me, here's your cricoid cartilage right here. Here's your cricothyroid ligament in between the thyroid cartilage and in between the thyroid cartilage and the cricoid cartilage. This is where a tube can be inserted through this ligament to provide an emergency airway. One thing that I'll mention, and can't remember if I mentioned it when we talked about the respiratory system in lab or not, but if you're familiar with Stephen Hawking, if you're not familiar with Stephen Hawking, you should get familiar with Stephen Hawking because he was awesome. But you're probably familiar with the Big Bang Theory, not the TV show, but the theory of how the universe was created and the idea that we have black holes in the universe. Those were all discoveries that he made. The reason I bring him up is because if you remember him, the reason he was not able to speak and had to speak through a mechanical computer was a botched tracheostomy. And it wasn't botched it was botched in that they did when he had a seizure that stopped him from being able to breathe. The reason they did not know at that point how, I don't remember how old he was when it happened, but they did not know at that point how to do a tracheostomy and not damage the vocal ligaments. And so when they did the tracheostomy on him that saved his life during that seizure, it nailed his vocal ligaments. And that's the reason that he never was able to speak again except through the computer. But you can see, looking at it, if this is enlarged, you can see how that could very easily happen. A smoker's cough, the deep rattling cough of a smoker that's linked directly to adverse effects of smoke on the respiratory system. The chemicals in the smoke act as irritants, increasing mucus secretion. Nicotine also partially paralyzes and eventually destroys the cilia lining the tract. The result is that more mucus is present, but cilia are less able to sweep it out. So you get more mucus, but you get partial paralysis and loss of the cilia. So the cough develops as the only way to prevent the mucus buildup. Cilia will reappear within a few months after smoking stops. So it's a paralysis of the cilia and the fact that you lose them and more mucus starts to develop and you can't eliminate it. So the trachea, the windpipe, conducts air from the larynx to the lungs, and it's supported by 15 to 20 C-shaped tracheal rings. These rings reinforce and provide some rigidity to the tracheal wall, ensuring that the trachea is going to remain open. Remember, this is all what we call the conducting zone. Keep this in the back of your mind for right now. This is all what we call the conducting zone. What kind of cartilage is it made out of? Except for the epiglottis, what kind of cartilage is it made out of?
Highland.
Right, hyaline. What do we know about hyaline cartilage? Is it flexible?
Yes.
Are you sure?
No.
It's very, very rigid.
Uh,
Okay, it's very, very rigid. Why would that be important? Keep that in the back of your mind for right now. Okay, so all the way down from our larynx through our trachea into most of our bronchioles and our bronchi of our lungs, it's all hyaline cartilage. On the very back of the C rings, after the cricoid cartilage, remember that's the only complete C ring, full ring of the trachea. There's a trachealis muscle. Right back here would be the esophagus. A mucosal lining with the mucus glands. And these rings are reinforcing and providing rigidity. So larynx, trachea, the dividing point separating the that's going to divide into the two sets of main bronchi, main bronchi is the carina. Looking at what I do is you count down. Here's the main bronchi or the primary bronchi. After the this is after the first of it, where the dividing point of the carina. The secondary bronchi right here, the second dividing point. Tertiary bronchi are the next dividing points. So here's your primary bronchi, secondary bronchi, tertiary bronchi, or segmental bronchi. So primary are also main lobe bronchi, lobar are secondary, segmental or tertiary. Then we are in the bronchioles, in the terminal bronchioles, and then the respiratory bronchioles. So the air passageways are going to decrease in size, but increase in number as you move down. If you remember, just curiosity and interesting is if you look at if you remember when we were looking at those sets of pig lungs, and my mom, who has a much better air capacity, was breathing into the lungs. And we were about right here. And we thought we were about right here, but we were about right here. And the reason I figured that out was because we thought we cut into right here and inserted the straw about right here. But if you remember, when she started breathing into the lungs, it only expanded a small patch about right here. Do you remember that? Only expanded a small patch about right here. because we were in a secondary bronchi that actually came up off here. Because when I started doing the dissection, the reason I figured that out was because when I started doing the dissection, I found the carina down later. And so if you remember, one of the first chapters of Biol 121 is talking about anatomical variation. Well, there you go. Because why would you have a secondary or bronchi or one that's way up here and then the carina down here? So conduction of inhale there from the to the alveoli. The nares, the nasal cavity, the nasal pharynx. Remember, the nares are the outer openings. The nasal cavity, the nasal pharynx, the oropharynx, the laryngopharynx, the larynx, the trachea, the primary bronchi, the secondary bronchi. Remember, the primary bronchi are also called the main bronchi. The secondary bronchi are the lobar bronchi. The tertiary bronchi are the segmental bronchi. Multiple branches of the tertiary bronchi leads into the bronchioles. Bronchioles lead into terminal bronchioles, and then respiratory bronchioles, alveolar ducts, and alveolar sacs. Up till this point right here, everything up is up, and over here is the conducting zone. All of this right here is the conducting zone. This is where the respiratory zone is going to begin. One thing that marks the respiratory zone and makes it different from the conducting zone is we have no hyaline cartilage anymore. Once we're in the respiratory bronchioles, there's no hyaline cartilage. Why would that be significant? Keep that and think about that for a minute as we move forward. Why don't let's take a break for a second and let's take, I don't know, 6 minutes. So we'll come back at 9:24.
All right. Thank you.
Welcome. I'll be right back. We'll look at something really quick and then we'll come back into this. I remember I have here. Okay. Okay. So general anatomy, the thyroid cartilage, cricoid cartilage, trachea, the carina, the main bronchi, the secondary bronchi, or the lobar bronchi, and the tertiary or segmental bronchi. In the right lung, there's 3 lobes. In the left lung, there's 2. So right lung, the superior lobe, the middle lobe, and the inferior lobe. The oblique fissure, the horizontal fissure, separating the superior and the middle lobe. Oblique fissure separating the inferior lobe from the middle lobe. In the left lung, there's only one fissure because there's only 2 lobes, the oblique fissure. And the indentation in the left lobe is, sorry, bear with me. Sorry, give 1 second. indentation here called the cardiac impression or the cardiac notch. On the mediastinal surface or the medial surface of the lung, the hilum, which is where the pulmonary arteries and pulmonary veins are going to enter and exit the lung, and the bronchi. The base is the bottom, the apex is the corner tip. So looking specifically at the respiratory zone transition, terminal bronchi, terminal bronchioles are made of simple cuboidal epithelium enclosed within a thick ring of smooth muscle and no hyaline cartilage. The terminal bronchioles are going to branch into two or more smaller respiratory bronchioles surrounded by a thin layer of smooth muscle. So this is where we have no cartilage. Remember that the blood that's coming in through the pulmonary artery, is it oxygen poor or oxygen rich? Coming
Poor.
in, it's poor, right? And this is the only place where we see that, right? Where we see that the pulmonary veins are the ones that are carrying the oxygen rich blood. Good job, guys. So terminal bronchioles are going to branch into smaller respiratory bronchioles that are surrounded by a much thinner layer of smooth muscle. Remember that this is the conducting zone is a series of tunnels or tubes. The respiratory zone is where gas exchange is predominantly going to occur. So the respiratory zone begins with the respiratory bronchioles, with the alveoli budding from the walls. Alveoli meaning a cluster of grapes. And you can see that the capillaries networks just surround and cover the alveoli. Looking at this, looking at confocal microscopy photo, the terminal bronchioles, respiratory bronchioles, going off into the alveoli, alveolar ducts now, and alveoli. This meaning a scanning electron microscopy. Where the capillaries coat and surround the alveoli. Shoot. Okay. At the end of the, bear with me here. On the surface of the alveoli, where the interface where the capillaries and the alveoli meet up, is the respiratory membrane. It's thinner than your average membrane. It's thinner than the excuse me, the capillary bed and you've seen the capillaries and the capillary bed and the alveolar surface. If you remember, they're both made of simple squamous epithelium. And typically they have the simple squamous epithelium, one layer, and then a basement membrane. The respiratory, with regards to the respiratory membrane, it has a shared basal lamina basement membrane. It's that thin, so that it's not that the capillary by itself has its own basement membrane and simple squamous layer, and the alveoli has its own basement membrane and simple squamous epithelium. It's shared. This is unique to the lungs. The type 1 alveolar cells have a very thin squamous epithelial cells. So I'm sorry, bear with me here. The type 1 alveolar cells in the lungs, we have two types of alveolar cells. We have type 1, which are very thin squamous epithelial cells. And these are the ones that make up 90% of the alveoli, and they function in gas exchange. The type 2 alveolar cells are cuboidal shaped cells, and they make up 10% of the cells, and they secrete surfactant. One other type of cell that we have here in the alveoli is the alveolar macrophages, or dust cells. These are phagocytes, so part of the immune system, phagocytes that are going to clean up and digest any stray debris that's not filtered out in the bronchial tree with the mucus. Your lungs are a really good place for an infection to start because it's smooth, it's wet, there's a lot of nutrients, and there's a really good entry, a lot of entries into the rest of the body through the blood. So we have the mucus, and then we have these alveolar macrophages that protect you. So pulmonary artery bringing in, forming capillary beds that surround and cover the alveoli. The respiratory membrane that is made of two simple squamous epithelial layers, one from the capillary, one from the alveoli, with a shared basal lamina layer, basement membrane. Three types of cells here within the alveoli. The type 1, which are involved in gas exchange. The type 2, which are involved in secreting surfactant. And the dust cells, or the alveolar macrophages. So each alveolus is surrounded by a web of blood capillaries supplied by the what?
B.
B.
B is in Bravo, yes. So pulmonary artery. The lung indents into the what? Indents into the blank of the left lung. Excuse me, the heart. I cannot read this morning. The heart indents into the what of the left lung?
The cardiac.
The
Cardiac.
Mhm. Cardiac
D.
notch.
D as in dog.
Yes. So any questions so far? Are we doing well? The pleura and the pleural cavities. Pleural cavities are the cavities that surround, that encase and surround each lung. It is formed by the pleural membranes, and there's a thin layer of pleural fluid that acts as a lubricant and helps hold the two membranes close together. Remember what I told you in lab? That I want you to think of the visceral pleura that directly adheres to the lungs and the pleural pleura that is adherent to the internal thoracic wall, so the internal part of the rib cage, as being essentially sucked together with this pleural fluid and under a negative pressure. Guys, this is crucial that you think of this way, because it will help, it will make the other parts more clear. So the visceral pleura that adheres to the lungs and the parietal pleura that adheres to the internal thoracic rib cage have this pleural fluid in between them that is a lubricant and works to hold them together under a negative pressure. So just a cross section, a figure from your book showing the visceral pleura and the parietal pleura. Thin layer of serous fluid. Pleuritis or pleural friction rub. Many conditions such as heart failure or pneumonia can cause inflammation of the visceral and parietal pleura or pleuritis. Pleuritic pain is one of the most common symptoms where there's chest pain with inhalation, resulting from inflamed pleura rubbing together as the lungs expand and contract. The rubbing can sometimes be heard with a stethoscope and is termed a pleural friction rub, which resembles sandpaper rubbing against itself. Pleuritis, inflammation of the pleura. And actually, I'm going to stop just for 1 second. Remember where we're at. Oh, why did I do that? I don't know. Just wasn't what I meant to either. Okay. All right, never mind. Let me open another tab. So remember, these are under negative pressure. And so if the rib cage expands, the lungs expand because the visceral pleura is tightly adhering and sucking onto the parietal pleura. And so if you expand the rib cage, you expand the lungs. There's a model, a very popular common model that is used for explaining the how this would work. And so if we were in the lab, you would see. Stop. If we were in a lab, you would see one of these. Down here, this is your diaphragm. The internal surface here is the parietal pleura. These are the visceral pleura, or the lungs. This opening right here is the trachea. So what's going to happen when I pull on the bottom and expand out the volume within here? What do you think?
It's going to inflate
What's going to inflate?
the lungs, or the
You're right.
pressure is going to
You're right.
increase.
Yep.
Okay.
So let's see what he does here.
And the rib cage and the opening here would be the trachea, and those bags in there represent the lungs, with the space between the balloon and this plastic being the pleural.
Sorry guys, bear with me just for a second. I'm going to try to get rid of whatever this is down here. Oh, it's stupid because I'm never going to respond to it. Okay, let's do this one more time because it isn't a very long video.
This bell jar here represents the rib cage, and the opening here would be the trachea, and those bags in there represent the lungs, with the space between the balloon and this plastic being the pleural cavity. Now, in us, the pleural cavity is filled with pleural fluid, but here it's air. This rubber band, this rubber sheet at the bottom represents the diaphragm. Now, in a real organism, the rib cage expands when you inhale, but here we're just going to drive it with the diaphragm. So when I depress the diaphragm, I kind of push it up here. But when I depress it by pulling down.
So when you depress it by pulling it down, you're contracting it. So this layer, this rubber layer here, this is your diaphragm. So you depress it by contracting it. Remember that for a few minutes here.
You can see that those balloons fill up. When I relax that diaphragm, the balloons deflate. When I contract the diaphragm, the balloons inflate, and vice versa. So thoracic cage, tracheal opening, balloons are lungs, space in between is the pleural cavity, and this rubber sheet represents the diaphragm.
Grammarly does more than.
Nope, stop. Sorry, talked into the computer a little bit. So when the rib cage expands, the lungs expand also. What happens to the volume? So the volume, when the muscles contract, the volume is going to increase, right? Say, yep, that sounds good to me. Yes, when the muscle,
That sounds good.
when the muscles contract, the lungs are going to increase also. Okay. So inspiration is defined as inhaling or bringing air into the lungs. Expiration, exhaling, is moving air out of the lungs. Air, just like water, just like everything else we've talked about so far, is moving from an area where the concentration is higher to an area of lower concentration. And when we talk about gas, concentration is now pressure. Or you guys, I mean, let's not even say that. Let's say this. Remember how blood flowed from a higher pressure to a lower pressure in the capillaries and in the blood vessels? It's the same thing here. It's moving from a higher pressure to an area of lower pressure. So it's moving with the pressure gradient. So you don't have to do anything, it just happens. Boyle's law says that under a constant temperature and a constant number of gas molecules, the pressure and volume of the gas are inversely proportional. Or it can be written as P1 over V1 equals P2, assuming P1 times V1, the first pressure and the first volume, equals the second pressure times the second volume. This is the process of pulmonary ventilation, where volume changes in the thoracic cavity and lungs are going to lead to a creation of a pressure gradient. Guys, bear with me just for a second. I forgot. So really quickly here, what this law means is that, let's say P1, and the way we measure P, remember, and when you think about pressures, we measure millimeters of mercury, because just know that we measure pressure in terms of millimeters of mercury. And so let's say that the pressure here is 760 millimeters of mercury. My kindergarten writing. And the volume is 1 liter. Okay, so the pressure inside this 1 liter is 760 millimeters of mercury. I'm going to shrink the volume. I'm going to make the volume a lot smaller for my second volume. So I'm going to exhale and make the volume in my lungs a lot smaller than it was before. I'm going to compress my lung cage. So it's going to be 0.5 liters instead. Now, the equation was P1, V1, equals P2 V2. How do I solve for P2? Basic algebra. How do I solve for P2?
Is it the formula for volume? Or
Well, how if I don't know what P2 is, how do I solve for it, Claire?
you
'Cause
divide. This
this
would be
is
like a division.
This is the only one that I don't know. How do I solve for it?
So you're saying P2? I'm getting confused because I'm looking at it as like a square root. I'm like square root property,
No,
but
it's not a square root. Don't look at it as square root.
I'm like, no, that's so 0.5 liters.
All right, let's rearrange the equation first. How do I solve for it? How do I rearrange the equation so I solve for P2?
Sorry, my cat just jumped in a bag and I didn't hear you. Wow.
If P1 times V1 is the same as P2 times V2, then you have to figure out the first part of the equation.
All right, well, how do I solve for P2?
Divide both sides by V2.
Exactly. So if I take this, to solve both sides for V2, this cancels out, right? This cancels out with my kindergarten writing. And this is what I'm left with, right? Equals P1, P2. Does that look right? Sound about right to people?
Yes.
Okay. So now I'm going to plug in the numbers. Now that I have the equation rearranged right, I'm going to plug in the numbers. So bear with me. I'm going to type this because I get tired of writing like a kindergartner. 760 millimeters, 760 times 1 liter. And then I'm going to divide this by 0.5 liters. Just like that. What do I get? What's my P2?
1520 millimeters of mercury.
1520. So if my volume goes up, if my volume goes down by half, my pressure goes up. Doubles. That's Boyle's law. If I don't change the number of gas molecules, bear with me, guys. I've got someone at my door. I'm so sorry. I don't know where she put it.
She said she had it on the fridge.
Okay. Hey, Matt. So if my volume drops by half, my pressure goes up by half. That's Boyle's law. So if the number of molecules is the same, and it doesn't change. As my volume shrinks, my pressure goes up. What's going to happen if the pressure goes up in the lungs and it becomes greater than the pressure outside?
If the pressure in the lungs is greater than the outside, they're inflating.
All right, but what's going to happen to the air within? No. Wait, let me say that one more time and make sure I said it right.
Okay, I could be completely wrong.
If
So-
the pressure, if the lungs shrink, and so now the pressure is higher in the lungs than it is outside, what's going to happen to the air within the lungs?
Would it increase? It's the opposite.
Is it going to increase if the pressure is higher inside? Where's it going to go? If it can move, where is it going to go?
Out.
If I expand my lung cage, all the air moves into my lungs, right? Because I've increased the volume and therefore I've decreased the pressure in the lungs. And now the pressure outside is higher than it was in the lungs. And that's why the air moves in. Is this clear? Is it becoming clear?
Yes.
If
Mhm.
I shrink my lungs, I don't have to make the air move. It does anyway, because I've now decreased the volume in the lungs, therefore increasing pressure. So using this little figure down here, and I got a syringe. Have a cap syringe where the volume, the gas molecules can't leave. I lift the plunger. Increasing the volume. It decreases the pressure inside the syringe, making air want to enter the syringe because the pressure is less inside. And things always move from a high to a low. Pushing on the plunger decreases the volume and increases the pressure inside. Increases the pressure inside. So I have here's my syringe, here's my lungs, here's my diaphragm. If I contract my diaphragm by bringing it down, it increases the volume within my syringe. And as a result, the pressure is dropped within the syringe and the air moves into the syringe. If I decrease the volume and allow my diaphragm to relax, the pressure shrinks. Seems to me the pressure goes up as the volume decreases. And the air leaves because the air pressure is lower outside of the syringe than it is inside the syringe. It's higher inside the syringe and lower outside, and therefore the air leaves. That's the way the lungs work. Was this clear?
Yes.
Oh, don't end the meeting, Mary. So in an open syringe, the pressure and the volume are at equilibrium. Lifting the plunger decreases the pressure because it's essentially this is contracting the diaphragm, creating a pressure gradient, and the gas molecules move to the area of lower pressure, which would be inside the syringe or inside the lungs. Pushing on the plunger decreases the volume, increasing the pressure in comparison to what's outside of the syringe or the lungs, causing the air to move out of the lungs. These two pressures are the intrapulmonary pressure, is the pressure within the alveoli. The intrapleural pressure is the pressure in the pleural cavity, which is always a negative, because this would be in between the two pleura. And then the atmospheric pressure. So we have three pressures. We have the intrapulmonary pressure, which is the pressure in the alveoli, which is the one that we're changing when we're working with the diaphragm. And the intrapleural pressure, which is the pressure in the pleural cavity, which is the which is the pressure between the two pleura. And then the atmospheric pressure is whatever pressure we're around. The difference between the intrapulmonary and the intrapleural pressure is going to keep the lungs from collapsing on themselves. Because remember, this is the negative pressure that is going to suck the visceral pleura up against the parietal pleura. It's always negative. When the intrapulmonary pressure is less than the atmospheric pressure, air will enter the lungs because the pressure is less inside the lungs than it is outside. When the pulmonary pressure is greater than the atmospheric pressure, the air is going to leave the lungs because the pressure is greater inside the lungs than it is in the atmosphere. And everything always moves from a high to a low. So your diaphragm and your external intercostals work to produce pressure gradients that result in pulmonary ventilation, moving air in and out of the lungs. When the diaphragm contracts and the external intercostals contract, they expand the volume in the lungs, decreasing the pressure within the lungs, and the air moves into the lungs. When they relax, they depress and shrink the volume of the lungs, increasing the pressure within the lungs in comparison to the outside air pressure, resulting in air leaving the lungs. the only time that your muscles contract that elevate your rib cage during regular, normal resting breathing are the diaphragms and external intercostals. They're the only ones that are involved in muscle contraction when we're just sitting here breathing normally, restfully, calmly breathing. And normal expiration, breathing out, is just a matter of those muscles relaxing. So they relax, shrinking the volume within the lungs. And so normal expiration is mostly passive and doesn't require muscle contraction. It's lung recoiling that allows for normal passive expiration. So in between breaths, so we go through these pressure changes during pulmonary ventilation, which is air moving in and out of the lungs. In between breaths, the intrapulmonary pressure equals that of the atmospheric pressure. And the result is that there's no change. At some point between breaths, there's no change between the two pressures. And so air does not flow. However, when the diaphragm and the external intercostals contract, they're going to expand the rib cage, which is going to expand the lungs. And the intrapulmonary pressure is going to drop in comparison to the atmospheric pressure. And air is going to move into the lungs. Between inspiration and expiration, the intrapulmonary pressure will then become equal to the atmospheric pressure. So air will stop flowing into the lungs until the muscles relax. And when the muscles relax, the lung volume shrinks, causing the pressure in the lungs to increase, and the air leaves the lungs, going out into the atmosphere until the pressures are the same. Is this clear?
Yes.
Let me say it one more time just in case. In between breaths, the intrapulmonary pressure equals the atmospheric pressure. And when those two pressures are equal, there's no airflow. When inspiration occurs, the diaphragm and the external intercostals contract, increasing the lung volume. The result is that the intrapulmonary pressure is going to decrease in comparison to the atmospheric pressure. And the air is going to move into the lungs. When the muscles, and it's going to continue to move into the lungs until the pressure inside the lungs equals that of the atmospheric pressure. When the muscles relax, the lung volume is going to shrink, increasing the pressure within the lungs. And the air is going to move out of the lungs into the atmosphere until the pressures are equal. Is it clear?
Yes.
One thing that we should mention here before we keep moving forward, a pneumothorax is when the intrapleural pressure increases to a level at or above the atmospheric pressure. So the intrapleural pressure, remember, this should be the difference between the intrapleural pressure and the intrapulmonary pressure should be a negative value. When it's not, that's when a pneumothorax occurs. And the result is that you don't have the lung expansion and the lung collapses. In order to reverse a pneumothorax, you have to restore that negative pressure again. So an opening between the pleural cavity and the outside air causes a loss of pleural pressure. The intrapleural pressure no longer exerts a suction effect that prevents the lungs from collapsing. And the added pressure enhances lung recoil, so lung elasticity, and the lungs immediately collapse. What are the most important, most numerous cells in the lungs? Do you remember from earlier?
B, type 1.
You're close. And I'm going to actually go up and look again because I'm wondering if I can clarify this one. I thought I did, but that doesn't mean that I really did. You know what? I don't think I fixed it. I think it's the dust cells.
Yes, in the book it says the most numerous of all lung cells are the dust cells. Yeah.
Okay, I'm sorry. I apologize, you guys. It's the dust cells. I didn't put it in the PowerPoint. It's the dust cells. Remember, those are the alveolar macrophages. So put under those alveolar macrophages, most common. So changing alveolar volume, what does this involve? The alveoli collapse upon exhalation because of elastic recoil and surface tension. There's a film of liquid, very watery liquid, and because of the adherence of water to itself, adherence and coherence of water, the water lines the alveoli. And just like surface tension of any surface of water, it's going to work to cause collapse of the alveoli. What allows them to easily expand again? Because if you think about it, it's a lot of surface tension there. The reason they expand again is because there's a surfactant, a detergent, that's going to reduce the tendency of the lungs to collapse by reducing the surface tension. So the alveoli tend to shrink upon exhalation because of the elastic recoil and the surface tension. Rather than say collapse, I should say shrink or become smaller. They expand again upon inhalation because of the surfactant, which is going to reduce the amount of surface tension, just like a detergent does. If you've heard of infant respiratory distress syndrome, which a lot of babies died of before we bioengineered, a lot of preemies died of, and some full-term babies died of before we were able to bioengineer surfactant. And now that we've learned to bioengineer surfactant, a lot of babies, very few babies actually die from this. My mother's older brother died of this. She heard later and has a pretty good idea that's why he died, was because the lungs weren't developed to the point of where he was secreting surfactant from those type 2 cells. And so if you've heard, you probably heard before that your first breath is the hardest breath you'll ever take. You heard that before? First breath, when the baby first cries, that's the hardest breath they'll ever take.
I've never heard that. That's very interesting.
Never heard that?
Ever.
It's why they want a baby to cry, because the second they start to cry, and my brother who worked as a clerk, ward, what do they call it? Ward clerk, floor clerk on OBGYN ward, I used to say, do they still flip them upside down and slap them on the butt? And he said, no, because they do enough that's going to make them cry. You know, they'll get them to cry. But the second they start to cry, their lungs should normally start secreting surfactant as soon as they expand their alveoli for the first time. And so that's why they work to get them, they want them to cry initially. When they don't have any surfactant, every breath feels like that first breath. Every breath is as hard as that first breath was. And babies die from exhaustion. You can't maintain that for forever. If you've had a cold that's made it really hard for you to breathe, you can imagine being a 5-pound, 6-pound baby and not being able to breathe and wearing out from exhaustion. So that killed my mother's brother. Her older brother lived for a few hours and died. And John F. Kennedy, right before he was assassinated, he and his, I cannot remember his wife, Jackie, they had a third baby that died from this right before he was assassinated.
The baby's buried with them at Arlington National Cemetery.
I didn't know that. Okay.
Yep.
Yes.
Okay, I'll have to go and visit again because I didn't know that. I'm glad they did that. So mechanisms involved in normal, quiet ventilation and forced breathing. The contraction of the diaphragm and external intercostals increases the thoracic and lung volume, decreasing the intrapulmonary pressure. So if you decrease the intrapulmonary pressure, the air moves out. Relaxation of the diaphragm and external intercostals, plus elastic recoil of the lungs, decreases the lung volume and increases the intrapulmonary pressure, causing the air to move out. Forced ventilation requires muscles outside of the diaphragm and the external intercostals. Forced expiration requires muscles outside of the diaphragm and the external intercostals. So forced ventilation, so forced inspiration is going to be aided by the contraction of accessory muscles such as the scalenes and the sternocleidomastoid to increase the pulmonary pressure to less than negative 20 millimeters of mercury rather than just negative 3. Forced expiration aided by the contraction of abdominal muscles and internal intercostal muscles is going to increase the intrapulmonary pressure to more than 30 millimeters of mercury or higher, causing more air to move out. So muscles typically involved in inspiration, the major ones are the external intercostals and the diaphragm. Ones that are involved in forced inspiration, sternocleidomastoid, scalenes, pectoralis minor, and internal intercostals. Forced expiration is going to involve the rectus abdominis, the external oblique. Keep in mind that regular normal breathing does not require contraction. Regular normal expiration does not require muscle contraction. It's just the relaxation of the muscles. The only time that it's the deep breathing that's going to use other accessory muscles. So accessory muscles also involved in breathing. Forced inspiration is using the scalenes, the sternocleidomastoid, and the pectoralis minor. Forced expiration is going to include the abdominal muscles and the internal intercostals. Alveoli expand when the pleural pressure is low enough to overcome any lung recoil. So in inspiration, just looking at the rib cage itself, in inspiration, the thoracic cavity expands laterally and vertically, and the intrapulmonary pressure drops, and the air flows in. In expiration, the thoracic cavity contracts as the muscles relax, increasing the intrapulmonary pressure, and the air flows out. Your book gives this diagram, and I think I've decided already that I wish I hadn't put it in here. When this is essentially the same diagram as this one was up here. This. I like this one better, I think. But at rest, the atmospheric and the intrapulmonary pressures are equal, so there's no net airflow. During inspiration, the intrapleural pressure is negative. So wait, that's on. The intrapulmonary, it's still negative, but the intrapulmonary pressure is negative, which allows air to move into the lungs. During expiration, the intrapulmonary pressure is increased in comparison to the atmospheric pressure. and the pressure and the air leaves the lungs. Pulmonary compliance is a measure of the ease with which lungs and the thorax expand. And you guys, I know we're running out of time. Stay with me for a few more minutes. The measure, so it's the measure of the ease with which the lungs and the thorax expand. The greater the compliance, so the easier it is for the change in pressure to cause expansion. Pulmonary compliance, or it's also called lung compliance, is how much pressure does it require for you to increase the volume of your lungs? How much pressure and how much work do you have to put into it? A lower than normal compliance means that the lungs and the thorax, it's harder to expand them. Conditions that decrease compliance are pulmonary fibrosis, pulmonary edema, respiratory distress syndrome, like that infant respiratory distress syndrome, when that surface tension is so high that it requires an exceptional amount of pressure for you to cause expansion. That's lung compliance. If it takes you so much pressure and so much work to increase that volume, your lung compliance is dropping. Your pulmonary compliance is dropping. Lung, pulmonary compliance, same thing, synonymous. So another one is increased resistance to airflow caused by an airway obstruction. So when you start to choke, or when you're anaphylactic, or deformities of the thoracic wall. Which of the following is the term for the lungs' resistance to expansion?
E.
B is in Bravo, Claire?
No. E. No, was that wrong?
It's wrong.
Okay.
It's B is in Bravo. So resistance to expansion, you know what? Does that sound, that doesn't sound quite right, does it? It's kind of a harder question. It's just not worded very well. Is pulmonary compliance. That's, according to the textbook, that's pulmonary compliance. Measurement of lung function. You guys, you had a lab on this, and I know a virtual lab on this, and we discussed it in lab. I think I'm going to skip through this for the sake of time. Well, actually, no, let's not skip through. The measurement of lung function. So spirometry measures the volumes of air that move into and out of the respiratory system. The tidal volume is the amount of air that's inspired or expired with each breath. At rest, it's about 500 milliliters. So this is normal breathing. Normal breathing. In an adult, it's about 500 milliliters, so half a liter. Inspiratory reserve volume is the amount that can be brought into the lungs forcefully beyond that of the tidal volume, which is approximately 3 liters at rest. The expiratory reserve volume is the amount that can be expired after expiration of tidal volume. So you're breathing in and out normally. How much can you possibly remove? That's your expiratory reserve volume outside of your, so beyond your tidal volume, how much more can you expire and breathe out? And it's approximately 1.1 milliliters or 1.1 liters. I'm sorry, 1.1 liters. Your residual volume is the volume still remaining in the respiratory passageways and lungs after the most forceful expiration. This is what's left in your lungs after you die. We were looking at those pig lungs like 2 weeks ago in lab. This is what made them really hard, because when I try to freeze, I freeze things so they don't get freezer burn or anything. I stick them in a bag and put the bag under water to push all the air out. That didn't work so well for the lungs because they still float, and they float really well because of the residual volume that's remaining in the passageways and lungs after the most forceful expiration. Talking about babies earlier, one thing, this is what they use to determine if a baby's body is found, a newborn baby's body is found. This is the way they determine whether it was born alive or dead. Excuse me, whether it was ever, whether it was what's the word for it? Whether it was whether it ever took its first breath. Is they take out the lungs and they weigh them, or excuse me, they take them out and put them into a thing of water, and if they float, the residual volume is still there, and they did take a breath at one point. Because that's the air that essentially never leaves. Let's stop here. And you guys, if we have time, our lab is, there's a lot of information, but it's not a very long PowerPoint. Let's, if we have time in lab, we will continue this, and I will try to finish. But have a wonderful hour and 20 minutes, and I will see you at noon.
Sounds good. Thank you.
Sounds good. Thank you.
Thank you.
Get in.
Thank you. So Jesse, Lauren, or Katie, are you here? Okay, I'm gonna end the meeting.